interesting topic today that they will talk about multidisciplinary speaking. Speaking up as an endorsement at bedside round in pediatric critical care department. So please, Susan and
Assalamu alaikum wa rahmatullah. Thank you very much, Dr. Aida, for this introduction. I just want to be sure first before starting, is the voice is clear? Because it was interrupting when we were listening to you, Dr. Aida. Is the voice clear now, my voice? I want to be sure that my net is connected well.
سوسن الصوت عندك يقطع فما أدري باقي الزملاء هم سامعين بوضوح.
It is clear, Susan. It is clear for us. Your voice is clear.
Okay, thank you very much. So, Bismillah ar-Rahman ar-Rahim. My name is Susan Yusuf. I will be taking care of being the moderator for this session. And we're going to have our speaker, Dr. Bashar Atayan. Dr. Bashar is a fellow too at King Fahd Medical City. She's one of the best fellows. She's going to present about a very nice quality project called Multidisciplinary Speaking Up Endorsement at Bedside Round in the PICU at King Fahd Medical City. This topic, it's really interesting and it's really very hot topic. We had a lot of concerns before we start this project, and alhamdulillah, after applying this project, things getting much better from different aspects. Dr. Bashar is going to go through these points, and we'll see how it's really very beneficial project. Okay, I think I leave the floor for Dr. Bashar, and if you don't mind, we'll leave the questions to the end of the session. Thank you very much. Please go ahead, Dr. Bashar.
Assalamu alaikum jami'an. Good evening. It's a pleasure and honor to be with you tonight, and all thank for Dr. Susan for giving me a chance to present this project to you today. So our project is Multidisciplinary Speaking Up Endorsement at Bedside Round in PICD at King Fahd Medical City. So speaking up is important for patient safety, but often healthcare professionals hesitate to voice concerns. Understanding the influencing factor can help to improve speaking up behavior and team communication. Ineffective communication is one of the most frequently identified root causes of sentinel events and contributes to the 400,000 deaths that occur each year due to preventable medical errors. Ineffective communication includes failure of staff to speak up when they know something is wrong that could potentially cause harm to the patient. Nurses have reported fear of retaliation, being reprimanded, how others will respond, and appearing incompetent as reasons for not speaking up. Nurses have also reported that they don't feel that anything will change as a result of their intervention. There are 4 ways to make interdisciplinary rounds more effective. Begin at a set agreed upon time and location. Having a schedule and expected start time is generally considered best practice. This keeps things timely and ensures that all necessary team members are present. Systemize team input. Establish an order for when each team member speaks or has the opportunity to speak if necessary. This greatly streamlines rounds and reduces the risk of tangential conversation and lapses in communication. Stay professional, pay attention, do not interrupt, ask clarifying a question as appropriate, mute your cell phone, and don't have side conversations with other team members, especially while another person is talking. Keep the goals in mind. Every team member is responsible for understanding the unique role and expectations and should be prepared to provide the minimum effective amount of information to support the team's overall goal. So this slide is clarifying the current process for the daily ICU interdisciplinary patient care rounds. Start by shift change. Nurses take handover and perform patient assessment and reassessment and complete their chart. Resident arrives to the ICU and takes a nursing care plan from the primary nurse to complete his progress note and plan of care. Then consultants arrives to the ICU with his team, start round joined by primary nurse if available, and charge nurse and some multidisciplinary team members. Then residents presents the case, may include bedside teaching, may include feedback of other members. Then plan of care system base is decided, documented at this point, or sometimes after round completion. Then team moves to the next patient till the end of daily rounds. Here in the current process, we have some areas of improvement, as you have seen here. So find an opportunity for improvement. An initiative implemented in PCV ICU to promote engagement of interdisciplinary team during patient rounding was taken as an opportunity to standardize the speak-up endorsement pathway among PICD units. Finding opportunities to improve the current interdisciplinary team endorsement during patient care rounding in PICD. Currently, there's no structured endorsement pathway, lack of engagement of multidisciplinary team, poor team dynamics, limited opportunities to share concerns related to patient safety, and limited opportunities to discuss unnecessary investigations and procedures, limited discussion about family support and engagement, variation among attending teams in conducting rounds. So understanding the current process, we have done fishbone analysis to identify the factors that affect the current process, starting by the management factor, like there's no standardized structured process during the round. And
can we ask everyone to mute his phone, please, or mute his mobile or the computer? Please, thank you.
Yeah, thank you, Doctora. So as we're presenting here the fishbone analysis that have been done to understand the current process and the defects in our current process. So the management factors like no standardized structured process during the round, no clearly identified roles and responsibilities for multidisciplinary team members, limited opportunity to discuss family concerns, and some behavioral factors as well, like discouragement due to previous bad experience, such as negative response, and little consideration of nursing concern, as well as no auditing for the efficiency about multidisciplinary team daily rounding, and no training regarding how and what to speak up during the multidisciplinary team round, and orientation program having limited training of speak up during rounds for novice nurses. And there's also the variation between consultants in leading the multidisciplinary team round, and some environmental factors like limited nurses engagement due to the limited continuity of care. All these factors lead to lack of structured interdisciplinary speak up during patient care rounds. So in this slide, we're mentioning the goals that has been set for this project and the team member as well. which was to create a clear speak-up endorsement pathway for the interdisciplinary PICU team patient rounding, and to conduct training for physicians and nurses to audit compliance with the speak-up endorsement pathway, and to develop staff satisfaction survey tool and measure staff satisfaction with the new endorsement process, and to measure effectiveness of the endorsement pathway through survey-related questions. So selected the desired outcome was to develop a structured speak-up endorsement pathway for the daily interdisciplinary patient care round in PICD unit by end of March 2021, and to provide education and training to the PICD staff like nurses and physicians regarding speak up and the new pathway by the end of April 2021, and to be able to achieve 80% staff satisfaction rate with the new pathway implemented among PICD team by the end of second quarter 2021, and to be able to achieve 80% and above compliance rate by multidisciplinary team with the new process implemented in PICD unit by the end of second quarter 2021. Here in this slide, we're showing the structure of the speak up endorsement pathway, which we will go through step by step. Here, it starts usually by the responsible resident or fellow or assistant describing the patient information, background data, and clinical presentation at admission, ICU length of stay and diagnosis, including surgeries, present weight and precautions. Then move to the primary nurse explaining the pain and sedation assessment scale that has been used. And then she will go system by system, neurological like sedation, drug and dose, muscle relaxant, drug and dose, Glasgow Coma score, pupils, and ICP monitoring, EVD if there is, and level of EVD, drain limit, and CSF amount in the last 24 hours. Then cardiac system, inotropic support, drug and dose, heart rate and rhythm, blood pressure, invasive or non-invasive, and central venous pressure, pulses, peripheral and central, refill time, color, extremity warmth, edema, and lactate with mixed venous saturation. Then to move by the respiratory therapist, describing the respiratory system, airway, respiratory support tool, respiratory support sitting if present, respiratory rate and saturation, secretions, amount and consistency and color, and blood gases. Then by nurse, we mentioned the chest tube, location, oscillation, drain amount and color, and by RT or resident or fellow, chest X-ray findings. Then again by the nurses, you will mention the devices, ETT, peripheral lines, central venous catheter, tubes and other devices, bundles, early removal, and laboratory investigation. They will mention the important result and date of planned procedure by residents or fellow, and then by nurse or respiratory therapist, the frequency of labs and blood gases. Medication review will be done by the residents, fellow, or the pharmacist if present. They can fill gap, like the doses, levels of drugs, and adverse events effects as well. Family review by any team member, any concerns from family to be shared with the attending team, updating the family regarding the plan of care. Then discharge plan, review and discuss the expected date of discharge from PICD by attending team and nurses. Then by responsible resident or fellow, fill in gaps at any point, consultations review and recommendations, clinical assessment, then problem list, and finish by the plan of care. So here we are mentioning the staff training on Speak Up endorsement pathway, which has been done by multiple methods, some of them face-to-face, payroll or simulation, and the audit tool for staff compliance with Speak Up pathway form as well, as you have seen here. So here we're describing the process after improvement. As again, daily ICU interdisciplinary round will start by nurse take handover and perform patient assessment, revise the previous care plan, and start documentation. Then assigns physician assess the patient, collect the necessary information, revise previous actions, and document the findings. Then round will start at 9:30 with the presence of the core team, including consultants, physicians, shift manager, primary nurse, and respiratory care practitioners. Then each team member present the case following the Speak Up endorsement pathway. Round will include bedside teaching and patient and family concerns. Then plan of care discussed among the interdisciplinary team and documented immediately. Team moves to the next patient and follow the same process till the end of the patient care round. So here we will mention the result of initial phase. Staff training, we could achieve 89% of PICU nurses trained and 100% of cardiac ICU nurses trained, 80% for PICU physicians, and 100% for PICU rotating residents. And here we're describing the compliance with Speak Up endorsement pathway till June 2021. Overall compliance was like 93%, starting from down till up. Physician presenting the patient information achieved like 93% compliance. Nursing prescribing the neurological assessment, 97%. Nursing prescribing the or presenting the cardiovascular assessment, 99% compliance. Respiratory care practitioner presenting a respiratory system achieved 87% compliance. And primary nurse presenting gastrointestinal and genitourinary system achieved 91% compliance. Primary nurse represent the frequency of investigation, achieved 93% compliance, and physician presenting medications and procedure achieved 99% compliance. Survey has been conducted as well among the BICU staff. So 121 staff has participated in this survey. We're just mentioning examples of some questions, like how was your training on Speak Up? 52% of them were satisfied with the training. And Speak Up flowchart is comprehensive. Again, around 50% were satisfied. And a new structured patient care rounding process add value to the quality of care provided to patient and family in PICU. 55% they were satisfied. And our overall satisfaction, their all satisfaction achieved 55% satisfaction, with 26% of them were strongly satisfied and 11% were neutral. Again, Speak Up improved performance. The majority of them were satisfied that the Speak Up improves the performance. Potential patient safety events can be identified and prevented through Speak Up opportunity during the structured rounds. 48% they were satisfied and 35% strongly satisfied. Speak Up improve multidisciplinary communication of patient management plan. Around 48% satisfied, with 36% strongly satisfied. And when we ask the team satisfaction with the Speak Up process, majority of them found the Speak Up is time effective, and it improves their knowledge, it improves their confidence, and it is organized, and speak up is easy. Practicing speak up is easy, and overall training on speak up, majority, like 53% of them were satisfied, though some of them find it a bit stressful, like 37%, which is normal for establishing a new thing in the daily round. And here the satisfaction rate in the survey. We could achieve 81% of staff satisfaction, and participants believes that speak up improves the performance around like 83%, which is above our target, which we were targeting like 80%. Here we're presenting our SMART objectives for 2022, which is to sustain the compliance with the speak up endorsement pathway and escalation process for the multidisciplinary PICU team patients round. And the second objective is decrease the number of PICU unnecessary routine blood test investigation and its related costs, which is new objective, and targeting more than 90%. In 2022, 150 staff has participated in the survey, and we could achieve 97% of satisfaction, and participants who believe speak up improve performance like around 92%, which is again above our target for 2022, which is 90%. A compliance monitoring with endorsement pathway, overall compliance was 100% from the staff, physician, nurses, and RT as well. So our new goal for 2022 is to monitor and improve the opportunities to reduce the unnecessary routine labs like CBC, UE, liver function tests, and coagulation during the Speak Up patient care round in 2022. So this graph here representing the opportunities to reduce routine labs, where the yellow bar representing the laboratory frequency shared by primary nurse, like once daily, twice daily, or TID. And the green bar representing primary nurse requested to reduce the frequency of laboratory investigations. And the gray bar represent the frequency of laboratory investigation decreased after has been requested by the primary nurse. So result from our audit revealed that speak up opportunities by the nurse increased from 35 to 55%. A second result was the action taken by the attending team to reduce the routine labs, which increased from 8% to 15%. Improved process. The main value added steps in the process includes patient care take place with core team members being present, clear roles and responsibilities identified. All members follow the endorsement pathway list, which provides system by system handover, opportunities for early removal of lines, and discontinuation of routine labs investigations. Quality conscience, doing the right thing. The project team successfully implemented the structured endorsement pathway for patient care rounding in PICD. As shown in the result for 2021 post-intervention period, the new practice was well adopted by all staff. Speak Up endorsement pathway and training is now part of the orientation program to PICD. So lessons learned and recommendations. Effective communication is enhanced when interdisciplinary team have a structured process for patient care rounding. Efficiency of rounding is improved and has multifold impact on staff satisfaction, patient safety, with opportunities to improve patient experience. Propose Speak Up endorsement pathway to be implemented in PICD for sustainability. Recommend speak up
Dr. Bishayr, we lost your voice, so I don't know if the others, they're still hearing you.
No.
No, we could not hear this slide. We could not hear her.
Can you check, Rosaline, please, with Dr. Bishayr?
Okay.
Walaikum. Sorry,
Oh, no,
I
no,
had
no.
just a technical issue. I'm back.
Oh, good. So, Dr. Bishayr, the last slide, lessons learned. If you can just repeat it.
Yeah, from here. So lesson learned and
Yes.
recommendation. Effective communication is enhanced when interdisciplinary team have a structured process for patient care rounding. Efficiency of rounding is improved and has multifold impact on staff satisfaction, patient safety, with opportunities to improve patient experience. Propose speak-up endorsement pathway to be implemented in PICD for sustainability. Recommend speak-up endorsement pathway and training to be part of the orientation program to PICD. Speak-up endorsement pathway and training can easily be adopted in other ICUs and best practice. So summary, interdisciplinary patient care rounds are a patient-centered model of care, emphasizing safety and efficiency that enable all members of the team caring for patients to offer individual expertise and contribute to patient care in a concerted fashion. Rounding as a unit allows for each discipline of the healthcare team to address their goals, issues, concerns, and daily care plan. The primary value of this design for team-focused rounding allows for efficient and transparent lines of direct communication between team members. Consequently, this reduces the negative impact of delays or misunderstanding in communication, leading to potential patient safety incidents. Cost reduction. Institute for Healthcare Improvement supports interdisciplinary rounding as a formal daily mechanism for identifying patient safety risk and determining the daily goals. Value and impact of structured interdisciplinary rounds is known to improve patient safety and care coordination, decrease length of stay, reduce routine daily labs investigation, enhance staff and patient satisfaction, all of which has a direct association with cost saving and quality care, which equals value. Strategy for improving the sustained projects. In 2022 expansion to adult and neonatal ICU, this project was presented at Critical Care Services Administration quality meeting and was well appreciated. In Q3 2022, it was selected by Critical Care Services Administration Medical Director for rollout to all ICUs at KFMC. Kickoff meeting took place on 8th of September 2022 with representative from adult and neonatal ICU, physician, nurses, and respiratory therapists. So lesson learned again, effective communication is enhanced when interdisciplinary teams have a structured process for patient care rounding. Efficiency of rounding is improved and has multifold impact on staff satisfaction, patient safety, with opportunities to improve patient experience and cost saving. Sustainability plan. Speak Up endorsement pathway will continue as a rollout project in the Critical Care Services Administration. Staff recognition and reward is planned for speak-up opportunities identified during rounding. Project team will finalize a regulatory document for the interdisciplinary patient care rounding once the rollout of the project is completed in 2023. Last slide. Recognition. This project has participated in National Patient Safety Award in 2021, as well as participated and won in Quality Day in 2021. Thank you all for listening. Sorry for the technical issue.
Thank you very much, Dr. Bashir. You really make it very simple and to the point. I really appreciate it. So basically this project started like in the PICD as multidisciplinary speaking up. We start main concern is for the nursing, number one, and the second is the respiratory therapist. For the nutritionist and the social service, whenever they're available, they will take part also in their section. So, but basically, the main concern was first is the nursing. So after starting this project, you could see that the nurses become more confident. They were speaking up. They will share their concerns. They were not keeping quiet or keeping themselves busy with other things when they see that the round started. So it's totally different. And we felt that there is a lot of changes has been happened after we started this project, and our plan is to sustain it and even to distribute it to adult critical care and NICU care in King Fahd Medical City. So that's our presentation, and I think the floor now is open for any question or any comment. Thank you very much.
Thank you, Dr. Sousan and Dr. Bashir. That was very well presented. It's a huge project that was simplified in the presentation and presented in a nice way. We do echo your idea that definitely speaking up during the multidisciplinary round definitely will empower our nurses, physicians, respiratory therapists, and the clinical pharmacist and the family. And it will increase the awareness about their patients. It will help organizing the process, decreasing risks and errors, and achieving the outcomes that are needed. I do have few questions, if you allow me just to say them all together, and then you have the time to answer them. Number one is, in your slides, you presented that ICU staff compliance and the training was around 81%, while for the rotating resident was 100%. Our challenges actually is the opposite. As you know, the ICU staff always we have like a limited number often that they will be around in the ICU, so it's quite easy to or quite reasonable, to get in the appropriate compliance, while it's the opposite with the resident, especially the outside rotating residents and so on. So what are the challenges that you face with training for the ICU staff? This is question number one. Question number two, do you have a family representative during the round that we're going to raise their concern, or the team member will raise their concern? And the question number three is, do you use checklist form, like, especially to make sure that we are covering all the morbidities related to the ICU, like central lines, if it is present or not, and the age of the central line, readiness for weaning and extubation, medications, lab works, any procedures, and so on. Those are the main questions, and thank you very much for this outstanding presentation. I really enjoyed the whole presentation from first slide to the last one. Thank you.
Thank you very much, Dr. Aida. We really appreciate these very important questions. Let me go one by one. If we're wondering why the complaints of the resident is more than the complaints of the staff, and the first, when we started the 2021, as soon as we started, we added this to the orientation booklet and orientation presentation for all the residents. So they were really very high complaints at that time from the residents. And as soon as we entered the second year, you could see that the complaints was almost 100% for all, including the PICU staff and including the RTs and the nurses. So as you know, that anything in the beginning, it might have a challenge of complaints, but later on, especially in the initial stage, some of the staff were stressed out, especially nursing, and you could feel them that when they present how they feel they are stressed, and even in the survey they show it that they were stressed out. But by time, maybe 2 to 3 times they're presenting, after that you will find them that they're totally opened and they're totally engaged during the presentation, and they are really changed with time. So compliance issue, alhamdulillah, we are now in 100%, so we're happy about this rate in 2022. Remind me, Dr. Aida, for the second question, was it about, I should have recorded, sorry for that.
Were
It
you
was your second question.
Yeah, were you involving the family members, or the team will present their concern?
Yeah,
And
actually, yeah, for during the round, no, the team will present the concern of the family. Any member of the team can present it, either the nurse, either the resident, fellow, assistant, any one of the team members. He heard or had communicated with the family, he will present the concern. Because at this stage, we prefer that we'll do the round and then we can ask and discuss with the family rather than interrupting the round. So that's the second question, sir. And the third question, Dr. Aida?
Hi. Third question: do you use a specific checklist form, for the nurses and the physicians that will cover all the ICU, aspects and factors that related to morbidities, like as I mentioned earlier, central lines, readiness for extubation, medications, lab works, procedures?
Yes, that's right. Yes, we have it in the endorsement pathway. These all are like a checklist for the nurses, and it's mentioned about the devices, all kinds of devices, how long it has been there and which side, and even the plan for these devices, when you're going to remove it. So all are mentioned in the pathway. Maybe Dr. Bashir can share us with the slide that it shows the devices part. So even the antibiotic wise, all has been mentioned, how long you're gonna keep it, and how long it has been there, and for how long you're gonna keep it. So this is also on the checklist. And we have like an auditing list that the auditing person, he will have also a checklist whether these are mentioned during the multidisciplinary round or not, or missed. So we have it in the endorsement pathway checklist, and we have it as auditing checklist also. Thank you. Did I answer your questions, Dr. Aida?
Yeah, definitely. Again, thank you for presenting this. We really take it for, a guarantee that the round is really structured, but it's not always the case. So it's a great work and great effort. And I hope that all the ICUs across the nation, they will have such a structured round, and to, empower every member in the team to speak up, especially our colleagues from the respiratory therapy. I think sometimes their role is really, underestimated. Um, they sometimes will stay silent, and the resident or the fellow or the nurse present the respiratory part. So I believe that once they are empowered to speak up, they will be always on top of, their work and top of the patient's condition, and this may help in either preventing complications or expediting the recovery stage by identifying chances for weaning, early extubation, early transfer, and so on. Thank you very much. And the
Thank
floor
you,
is
Dr.
open
White.
for any other questions. If anyone have a question, please raise your hand and unmute yourself.
Yeah, I could see that some hand raising. Ms. Shania and Ms. Gosia and Dr. Hani Timsah. There are some hands are raised. Please, they can unmute themselves, isn't it?
Yeah, thank you very much, Dr. Sasan and Dr. Bashir. I think this is need of time to have a regular endorsement, a uniform endorsement. And I think this will help that speak up pathway. This should help. And I was really wondering, and I really appreciate Dr. Ida's question, that was there a checklist, which is really very important to bring the uniformity. And my question was this only, but you said you are mainly concerned with the nurses and you're mainly concerned with the respiratory therapist and the nurses. I think clinical pharmacist as well, and our residents as well. If we have a printed material with us, like a checklist for each one for one patient, and you finished around, for example, 18 patients, and you have 18 papers as a checklist, and it would at the end be very good, and it will be very easy for the audit people to come and do the audit on those papers. Once again, thank you very much, Dr. Bashir and Dr. Sasan.
Thank you very much. We appreciate your question. Yeah, we have the checklist and it's very clear. Can you please share it again? The endorsement pathway checklist, it's include all the parties there. Maybe we did not put it all of it here, but again, Bashir, please share it again. So it has, yes, just go to the, okay. Okay, this is the full checklist. Maybe it's not very clear here, and each part who's going to present it. For example, the patient information data is going to be presented by the fellow or assistant, and then the nursing part, she will start from head to toe, from CNS, cardiovascular, GI, GU, then the respiratory therapist will go for the respiratory therapist part. And then the devices here, the nurse is going to mention all the lines and the tubes that is there, and the bundle early removal. She's going to mention the investigation, and she's going to mention the frequency of the lab investigation. And that's the new project, that the physician will be responding to the frequency of the lab, whether he's going to continue the same or he's going to change it. And as you can see here, the medication review, the doses level, and this is if the pharmacist is available, he has to mention it and he has to fill in the gap. If it's not available, the pharmacist during the round, then the resident or the fellow has to mention about the medication review. Again, the family review, as you can see, by any team member. Any team member can mention any concern from the family. And then at the end, we'll have the discharge plan, and that will be by the attending team and the nurses, what's the plan for this patient for the discharge plan. So each one has its part, even the pharmacy, pharmacist and the nurses and the RT and even the dietitian, if they are available, they have their part. If they're not available, then the nurse will present their part. So that's what we're talking about, the checklist. Thank you very much. I hope I answered questions. Okay. Shall we take another question?
Assalamu alaikum. Can you
Assalamu
hear me? حياكم الله. Thank you very much.
Perfect.
I really, it's really an honor to see such a high caliber quality improvement project in a PICU setting that gets rolled out to the hospital-wide ICUs. I think that's a wonderful, wonderful achievement. So really, I want to first of all congratulate all those involved in this project. Again, it's just the tip of the iceberg. Usually these projects take a lot of efforts and collaborations, and some people will be with us, some people you will have resistance. My question is, during your rollout, during, sorry, there's some mic. So for the time constraint, did you have any extra time that you found the rounds, especially in a busy unit? So did it require more or significantly more time, or was it comparable to the previous pre-implementation timing? I.e., so do people need to present, for example, the resident will be presenting his presentation or her presentation, and then the RT will be also repeating part of it, the nurse will be repeating part of it, or no, they are in harmony together, they are interconnected during the presentation, so it doesn't cost more time for the efficient time in the busy unit?
Thank you very much, Dr. Hani, for this valuable question. Actually, the endorsement pathway, as you could see, that it's everyone will go in harmony with the others. Okay, there is no repetition, there will be no overlapping, but they will be filling the gaps in between. So if something is missing, then the other team member will take over and present it. But it's very clear pathway for each one. Everyone knows his role and his responsibilities. So this is the very important part, that the role and responsibilities are determined from before. So everyone knows his part and when he's going to intervene, when he's going to talk, when he's going to present. I think timing wise, it's even much better than before. It's more organized, and we work together in a harmony way. I hope I answered the question, Dr. Hani.
Yes, yes, you did. And my last, maybe a quick question, or if you, did you publish this or not yet, or is it possible to share at least the pathway with other PICUs, so we can, probably most of us are doing something similar, but I think I like the way you made it systematically, documented and done systematically. So maybe if you didn't publish it yet, hopefully it's coming soon, or perhaps you can share with us some of the documents if it's okay in the group. I think that would be amazing. Thank you again.
Thank you very much, Dr. Hani. Yes, it's our pleasure to share it with you. And that's the aim, is to spread this pathway to all ICUs in the kingdom, because it's really very helpful. We found it really very helpful. This quality project, it's in its way for publishing, or for publishment. We already started and we're working on this. And we are very happy to share the endorsement pathway with everyone. It's really very helpful. Thank you. Please, if anyone have a question, just please pop in and ask the question. Do we have to unmute you, or you guys, you can unmute yourself?
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
مساء الخير. أديب خواجي من المستشفى العسكري في جدة. Thank you for your nice presentation, Dr. Sousan and Dr. Bashir. It was really great initiative, and I enjoyed this presentation, and such a challenge in a big unit with trying to make a team harmony and managing the time. I'm just gonna frame it in the question of Dr. Hani again. What corner of time management we are depending on to have such handover for each patient in a big unit? Like, are you speaking about time frame, or this collaborative part can be filled pre-rounds by allied health, and during the round will be maybe the main part, which is like the fellow and the resident and the consultants, because I can just imagine the round with dietitian, physiotherapist, respiratory therapist, social worker, and the AST program, rehabilitation program, chronic complex programs. Like we're gonna spend like most of the day in 3 or 5 patients. So are you guys dividing this great initiative in like multiple parts of the day? Like in the morning handover, it will be pure physician, and like pre-round, all of this allied health services, they start like the speak up handover communication tool. And then during the rounds, it's just some kind of cap up for what happened during today discussion, and the round will be directed to the plan. Just my main concern, I don't want to fill in a time gap that can delay the rounds for longer time, and it becomes such delay in the management. So what time gap are we speaking about per patient? Or is it just divided per whole day time management?
Okay, thank you very much, Dr. Adib. Usually the rounding time in the PICU start at 9:30. I'm saying bedside round morning rounding 9:30, and it has to finish 12, before 12 even. So that's, we have a fixed time for round, and this we go through the endorsement pathway for each patient, and we have been managing the time every day, and we didn't face really like prolonging in the endorsement or prolonging in the round after we established this endorsement pathway. We felt that it's much easy and it's more convenient for everyone. And as I mentioned, there is no overlapping. There is no gap in between them, because everyone he knows his part, and when he talks and what he has to present. So if we are talking about, for example, medication, if we have a pharmacist, he will talk about medication. If there is no pharmacist directly, you will find the fellow or the resident, he will talk about the pharmacy part or the medication part. Respiratory therapist, he knows that this is his part. So it's all led by each person. For example, we start by the patient, that the resident or the fellow present the patient information, what has been done last night, when he was admitted, how long he has staying in the PICU, blah, blah, blah. And then the nurse will start head to toe, and she will direct. For example, she will start with the CNS, cardiovascular, and then she will ask respiratory to take over. So respiratory will speak up, then she will continue again with the GI, urinary system, and so on. So we didn't face any prolongation of the round since we started this project. I feel it's the opposite. We feel that even we do finish before the time. So if you went through it systematic, you will find that it goes like systematically and very fast, and like a routine. It will become like a routine. That's my, I hope I answered your question, Dr. Adib.
Thank you, Dr. Sarsan. That was great initiative. Thank you.
Thank you very much. Okay, we have Dr. Iman and Ms. Shani. Please go ahead.
الو السلام عليكم جميعا.
وعليكم السلام، تفضلي.
Thank you, Dr. Bashir, Dr. Sausan, for this nice talk. I like the project name, Speak Up. I think what I understand, you are trying to focus on the primary nurses. I mean, they are the eyes of, they are our eyes for the patient. I mean, they are staying longer with the patient. So if we start encouraging them, give us better endorsement, don't hesitate. And I think this will help us a lot in deciding many things. Like if they give us a better estimation of the sedation, they can measure the sedation score, they can measure the withdrawal score. This will help a lot in deciding further plan for such patients. So I think we should encourage our nurses, not just our residents, to speak up, and this will help our patients. Thank you.
Thank you very much. I really appreciate your comment. Yeah, it's primarily we meant this for the nurses initially, and we're gonna make it like 2 stages. Currently is the nurses and the RT and the physician. Next, whenever we have a regular social worker, pharmacist, and nutritionist with us, we'll make it like a mandatory for them. But till now, we cannot have them on daily basis round. So, but the people which we have them on daily basis round is the physicians, the nurses, primary nurse, and the respiratory therapist. And that's our stage 1 of this project.
Good luck.
Thank you very much. Any other questions?
May I add just a quick comment to what just Dr. Iman mentioned, that yes, for our nurses to speak out, I think all of us, we don't need to wait for a project to be launched in our PICU. Let me just give you share a quick example. Usually in the weekends, when we do the rounds in the PICU, I give the rounds to be nurse-based. So the nurse will be presenting the case, and the resident will be the vice versa, just filling any remaining gaps from the medical physician perspective. So I think all of us, this is an excellent point that was raised by Dr. Iman, not to wait for a full-scale project to be launched. I think it's very important, all of our team, nurses, physician, RTs, dietitian, all of us, a social worker, and the families. Hopefully in the future, you may integrate the families in your phase 2 in the future. But I think it's very important for us to keep in mind to listen for the others and make this closed loop communication benefit our patients. Thank you again.
Thank you, Dr. Saleh. Dr. Shahri.
السلام عليكم يعطيكم العافية. Thank you very much, Dr. Sosan, Dr. Saleh Shahri, King Saud Medical City, Riyadh. I find it very, very good module to try to implement the good comprehensive rounds that number 1, tackle most of the patients related concern, and second is to let the people really share. And once the people knows that they have to share, then they will prepare in advance to to review their patients very well before the round, ending up by having very good care. And this is the goal. At the end, you need to have everybody around participating in the patient care, knows about his patient in advance. Now, I have some different thought about the timing of the round starting 9:30, which, I feel a little bit this is late, but I benefit from the whole structure that if you fit, for example, some centers differ from others in terms of the level of acuity, number of patients, big unit, small unit, and considering many things. Number 1, if you make it in a big unit at the time of closing round, sometimes it may be very thorough for the whole day. Everybody will reflect what have been done truly for the patients, reflecting the whole day, the care that has been done by all the contributors. So while if you do a very brief service round early morning, led by, for example, the fellows and the supervision of the consultants, you might fill in the addressing the main problems that the team will work on, and then they will reflect on the closing round in more details. I have a concern about the fatigue of the team whenever the loop get more prolonged and wide. And I see your the most compliant or satisfied is the resident, where they are having the the power to stand, tolerate the physical maybe pain. While the consultant, if you share there, I want to really interestingly see what's the opinion of the consultant. Number 3, or they might not feel it because they're the team leader. Number 3 is the educational needs of the team around. So, for example, the fellows, they might need to hear more specific related task about their competencies needed. So there is some difference in the team's needs in terms of the educational needs and their interesting aspects. Although at the end it is a care, so everybody have to contribute. I'm just wondering if some you have, Dr. Sousan, some other modules, and I hope in the future you can give us your view about different modules. Like, for example, when you do the safety round, a very specific, separate round, what does it mean in terms of the care? Does it really help separating it from the routine rounds? Number 3, what I want to say here, do you make it all standing rounds, or you separate some of them as setting round? Thank you very much.
Thank you very much, Dr. Saleh. If you gonna concentrate about this endorsement, speaking up, the nurses, they will not be the same nurses. So they won't be exhausted because you're moving and each patient has different nurse. So the nurses won't be the same. The number of patients will be distributed to the different residents. So at least you have 3 residents or 4 residents. So the number of patients, they're distributed on it. The second is also the fellows and the assistant. There will not be 1 fellow or 2 fellows. So it will be distributed to everyone. So it's a standing round, okay? And again, I'm saying that if you go with this algorithm or this pathway, it won't take a long time, okay? So things will go very organized, very systematic. So you won't be going here and there. And there are a lot of teaching point out of it, training point for the resident and for the fellow during the discussion. At the end, what's your opinion? How are you going to manage this patient? What is so and so? So there are a lot of training opportunities during this also endorsement pathway. So, and I wish everyone try to do it, and you would really appreciate the difference. Especially when you have, because the most important person that you need to hear from him is with you, the nurse. And she's gonna give you a very detailed, because she has been with the patient for a long time. So she will give you a very good detail about all the things that in your mind. Even the integumentary sessions, the infectious part, she will mention, as I mentioned, the devices, the laboratory. It really makes a difference. And by this way, you will not lose or you will not miss any points. Before you were, like, for example, the lab, we keep the patient on doing like PID lab, Q6 hourly lab, and it's missed. Now, no, you would know, okay, that she will tell you, then you will decide to decrease it. Also the devices, we were missing like the urinary catheter for how many days, the central line for how many days has been there. But with this pathway, no, well, it's really helping us, and it's for more patient safety and better communication with all the members. I hope I answered your question, Dr. Saleh. Thank you very much.
Thank you.
Any other questions, guys? Did I miss any raised hand?
May I just, Dr. Sousan,
if in high level of acuity units, when there is, you know, events going on, do you does somebody step out of the rounds, or you're assigned somebody who is just only looking through the acute issues outside the round?
So it's usually done like if you're doing the round and there is an acute event happening there, so one of the fellow or assistant will go and check that patient, okay, and the rest can continue the round. So we're not gonna, fellow and resident will go and check the acute events. So that won't interrupt the round itself. Did I answer the question, sir?
True. Yes, yes. And you never, it has been addressed before by Dr. Aida, you never had family, you know, around the patient when you are rounding, and you share, you let them share or ask during the round, or it is not established in your area, your unit?
In our endorsement pathway, we usually done this, the family review by any team members can mention it, but it's not the family members themselves. At this stage, we don't involve the family member because that will prolong the round and it might, I mean, take the round in different direction. So we keep the family review to be mentioned by any concerned party of the member, but not the family themselves. And when we finish the round, we go and discuss with the family if they have any concerns, or we can discuss with them what's the update and so on, but not during this endorsement pathway directly with the family, no.
Yeah, sorry, Dr. Asawsan. What, okay, I see the satisfaction very, very good. What are the, you know, KPIs you think that you need to assess in terms of, you know, the value of this project, or you need to adjust in the future? What are the things from your perspective you think we need to be concentrating on? I mean, what other factors we need to assess? I mean, negatively or, you know, positively for such rounds?
Okay, sustainability is number one. We need to sustain it. Okay, otherwise we'll lose all the efforts. Then the distribution of the ideas to all the critical care areas. The persistently have the compliance with this projects, and the satisfaction also. That's one of our important KPI or outcome, and rules and responsibility for each person. So that's what I would think about it. Negativity, I don't think we didn't face any negativity later on. Initially we did with the nursing. They were stressed out initially when we started the projects, and there were a lot of resistance. But then after training, we used different models of training, like role playing, direct education, face-to-face education, simulation also we use for training of the nursing and the staff. So after training and after practicing, it's most of the stressful points that they were raising, it has almost disappeared. And you could see them during that round, how confident they are in presenting, comparing to when we started the project.
That's excellent. Thank you very much.
Mm-hmm.
Thank you, Dr. Sousan and Dr. Bishair and all the colleagues who participated in this very effective and informative discussion. I think this talk has a lot of, you know, ideas around it, especially, you know, the rounding styles, timing, and so on. But I believe we already behind with the time. So thank you, Dr. Sousan. If there is no more questions or comment from the colleagues. it seems we are done with the questions. So really thank you for King Fahd Medical City and the colleagues there. They are always supportive. Thank you for all the attendee who are all excellent attendee always. Thank you for everybody participated in this talk. إلى اللقاء.